One of the most important topics in medicine is fluid and electrolyte balance. The electrolytes cannot be taken without keeping in consideration the fluid level in the body, because the electrolytes are suspended in the fluid, and so therefore they are measured according to how much fluid there is. Of the various electrolytes, which are sodium, potassium, bicarb, chloride, calcium, the most important one is sodium. The reason for that is because sodium maintains a tone inside the plasma, and it makes sure that the plasma stays intact. As such, it does not leave, the water does not leave the circulation and go out into the peripheries. And so therefore, it's important to maintain an adequate sodium level. Not only that it's important for homeostasis, but sodium is also important as a carrier molecule on which a lot of absorption it depends. For instance, the absorption of glucose is dependent upon sodium as well. The body makes sure that the sodium stays in a certain range. It's just like potassium or chloride. So there is a range for all of them. They're called as the normal ranges. The normal range of sodium is 135 to 145 millimoles per liter. And here comes another question about what is the meaning of liters. Here we've got two terms. One of them is osmolality and the other one is osmolarity. They're both interchangeable. They don't really mean any different from one another. But osmolarity is the amount of solutes which are present in a liter of water, while osmolality is the amount of solute or the number of solutes which are present in a kilogram of water. For clinical purposes, they're both interchangeable. They don't mean much. It's just when it comes to laboratory measurements, the way you can use osmolality as compared to osmolarity. The easier way to remember that is larity is liter and lality is kilo. And this way you can remember. So it's the amount of solute suspended or present in a liter of fluid and the amount of solutes present in a kilogram of fluid. The difference is that when it comes to osmolarity, it is dependent upon the water, the amount of water that is present, upon the temperature, and upon the pressure. So these are the three variables which are important when osmolarity is calculated. On the other hand, with osmolality, these are not calculated. So these variables are not important. But nevertheless, you will often find that you'll see millimole per liter. Whenever you see a formula, for instance, you look at sodium, you see sodium is 135 to 145 millimoles per liter, because this is how bodily fluids, both the electrolytes are calculated in bodily fluids. So the most important of the electrolytes is sodium. As I've said, it's extremely important to maintain a homeostasis. And sodium imbalance is once again one of the commonest imbalances which we see in clinical practice. Probably not a week goes by when doctors from all walks of life they come across a sodium value which is less than 135. So a value of less than 135 is called as hyponatremia, and a value of greater than 145 is called as hypernatremia. And as you can easily guess, that this is per liter. So this value is in relationship to the water content. And so therefore, whenever you look at hyponatremia or hypernatremia, you're actually looking at the water as well. Although water is not calculated when you're looking at that. You're just measuring the sodium, but you're actually indirectly looking at the water as well. Why are they important? Because low sodium ultimately will lead to changes in the tone of the plasma, and it causes fluid shifts. The three compartments of the body where fluid is present, one of them is the intracellular compartment. Now, this is a fairly constant compartment. This is composed of about 30 liters of fluid. As you know, the weight about 60% of our body weight is in fluid. Then there is a second compartment which comes in, which is the interstitial compartment. And the interstitial compartment, approximately, it's about 10 liters. And the third compartment is the plasma, which is actually the blood that is flowing. And this is approximately 5 liters. So altogether, this is 45 liters is the amount of water that is present in the blood. And this amount of water, this also makes sure that the sodium level stays in the same range, which is between 135 and 145. If there is a change in the sodium content here, for instance, if I increase the sodium content here, to say for instance to 150, the blood is going to become hypertonic. So it will have more tonicity. And by a simple act of diffusion, water is going to shift from the other compartments into the plasma compartment and thereby to neutralize this. So in order to bring it to balance, that's a simple diffusion. So when that happens on a short time, you won't see any clinical consequences. But if it continues to happen, and if there are major shifts of water, the intracellular compartment will be depleted from water, and so therefore this water content may drop to about 20 liters. And when that happens, the cells will shrink. And when the cells shrink, especially the cells in the brain, when they shrink, then that can have quite disastrous consequences. So therefore, this water balance is maintained by these three compartments: the intracellular compartment, the interstitial compartment, and the plasma volume. And this fluid is interchangeable, and a lot depends on what the sodium is. So you can imagine that how critical sodium value is, because sodium value maintains the sodium value in plasma ensures that the cells they work properly. The cells of the myocardium, the cells of the brain, the cells of the muscles, they work properly depending on the sodium level. And that's why hyponatremia or hyponatremia is so important to be diagnosed and to be treated adequately. So, what really is hyponatremia? Hyponatremia is that you've got water and then you've got salt suspended, and this is about 135. So hyponatremia can be of basically there can be three reasons for that. One of them is called as the U euvolemic hyponatremia. In a euvolemic hyponatremia, the water and the sodium, they will both fall together. So you'll have loss of water and you'll have loss of sodium. They'll both fall together, and you'll actually have low sodium that is going to fall, and likewise you'll have low water as well. The commonest causes you can imagine from cause of euvolemia is that there is fluid loss. For instance, there is fluid loss from excessive sweating. There is fluid loss from excessive GI losses. Somebody's got diarrhea, or somebody is actually being given diuretics. There are three areas from where you lose fluid and salt. One of them is sweat. The second one is the GI tract, and the third one is from the kidneys. There isn't a fourth one. All the other ones, which are probably because of internal shifts. But the losses, there are just three areas where you lose something, and these are the three areas where you lose. So one of them is euvolemic hyponatremia. The second one is hypervolemic hyponatremia. In hypervolemic hyponatremia, you increased the water from this to this. The salt remains the same. Nothing happens with the salt, but you've increased the water inside, and so therefore this dilutes sodium, and the sodium falls down. So in hypervolemic hyponatremia, you'll have low sodium as it is measured, but the sodium actually content may be entirely normal. So the sodium content may be entirely normal in this one, in this situation, which is the hypervolemic one, but you've actually increased the water in this situation. So you've got euvolemic, which is also called as isovolemic or isotonic hyponatremia. The other one is you've got hypervolemic hyponatremia, and the third one is actually hyponatremic hyponatremia. In hyponatremic hyponatremia, as you can see, you lose sodium in comparison to water. So you're not going to lose as much water, but you lose excess amount of sodium. Now, how do you lose sodium? Once again, losses are the same. Either you lose it from the kidneys, from the GI tract, or from excessive sweating. But hyponatremia, this has some other sides to it as well. And one of them is that you can often see is one of them is hypertonic hyponatremia. And the other term that you'll often come across is pseudo hyponatremia. In hypertonic hyponatremia, you've got excess of certain other things, especially glucose. What glucose does is, if you've got excess amount of glucose in the blood, then it creates a state of hypotonicity because it's an active ingredient, and this is going to suck water from these spaces into the blood, and so therefore temporarily cause a measured hyponatremia. The sodium value may be entirely normal, as was the case here. So the sodium value may be entirely normal, but when measured, this actually causes because of the shifts of the water, which actually goes from one compartment onto the other compartment, right? Now, the next is pseudo hyponatremia. In pseudo hyponatremia, this happens when there is a triglyceride problem. So if you've got excess of triglycerides, you'll get pseudo hyponatremia. There's another condition in which you get pseudo hyponatremia, and that is when there is excessive plasma proteins. In two conditions, you'll get pseudo hyponatremia. Pseudo hyponatremia is a condition in which the sodium, once again, is entirely normal, but it's a measured hyponatremia. So excessive amounts of triglycerides and excessive amounts of plasma proteins, they'll create a state of, once again, hypotonicity. And when measured, you'll get hyponatremia. And so therefore, the labs will have to make special preparations in order to check for the sodium. It doesn't happen at a normal triglyceride level or even slightly higher triglyceride level, but usually seen when the triglyceride levels are in excess of 1500 milligrams. And this is often when you see pseudo hyponatremia, but you don't see it otherwise. On the other hand, with hypertonic hyperglycemia, if you give somebody excessive amounts of sugars or if they've taken too many sugars, you can get that. But there is a formula for that. And that is for every 100 milligrams of sugar above 100 milligram may cause a sodium decrement of up to 1.6 millimole. So in other words, above 100 is the baseline. From that baseline, for every 100 milligrams, so for instance, somebody's got a blood sugar level of 200 milligrams, you can expect a decrement of sodium of 1.6 millimoles. And likewise, if somebody's got, for instance, 300 milligrams of blood sugar, you would expect the sodium to be lower, even lower, to about 3.2 or even more than that millimoles when it is checked. So this is actually called as hypertonic hyponatremia. So whenever you get a blood report and you've got a low sodium level, you must make sure that you are actually ruling out some of these things. Now, how do you approach a patient who comes to you with hyponatremia? And as I said, it's one of the most tricky things in medicine. Say, for instance, you come on a Monday morning ward round. You know that there aren't any new patients who are admitted over the week, and you're very happy that all the patients that you're going to see are the patients who were there from before. You know most of the histories, but on the second or the third patients, you see an electrolyte report in which the sodium level is, say, for instance, 128. Even for an experienced physician or for somebody who's actually seen these sodium values very often, the sudden impact of a low sodium level, it raises an alarm, because you not only have to actually work out why that's happened, but you also have to look at the consequences. That if it remains untreated, what are the consequences? And then sodium, it has to be brought under control within the next couple of days. So, for instance, if you see a sodium level of 128, the first thing that you do is to compare that with the previous day's report. and those reports are valuable. Sodium level in an instant, it doesn't have any meaning. It has to be compared. If the previous day's sodium has been in the same range, then you know what you're dealing with probably is something called as a chronic hyponatremia, and this usually does not have acute clinical significance. But if the previous day's sodium was normal, like 134, 135, but all of a sudden you see it to be 128, then this will have clinical significance because acute hyponatremia has more neurovascular and homeostatic implications as compared to chronic hyponatremia. You may often see elderly people coming in with sodium levels in the range of about 130, 132. And they've been there for months. And people who've got hypothyroidism, people who are taking several kinds of medicines. For instance, they've been taking antidepressants. For instance, they've been taking glibenclamide, etc., etc. These are the ones which can cause chronic hyponatremia. So they are the ones that you won't really be much worried about because it's chronic. But for those ones who just present acutely, they are the ones who may actually have a problem. So how do you approach such a patient? Apart from actually making sure that this is acute or this is chronic, then you look at the other electrolytes to see what it is. You look at the blood sugar level. You look at the medicines, what they're taking, if whether or not there was any new medicine which was started. If you think that they may have euvolemic, then the patient often will be hypotensive. The patient may have signs of dehydration, may have a high pulse rate, may have a postal drop, may have very low skin turgor. So you have to make sure this is the case. Give them normal saline. If they can take salt and water orally, fair enough. If they can't, then give them normal saline. And the treatment for juvenile hyponatremia is by giving them sodium chloride. But people who come with hypervolemic, you have to differentiate between a few things. First of all, whether excess fluid was added in, like somebody gave them IV fluids, somebody gave them loads and loads of dextrose water. Not uncommonly in a post-surgical patients, you see often that the patients are given dextrose water post-surgically. These are the patients who already are in a state of shock. They've got hyperaldosteronism, and on top of that, they're given 5% dextrose. So not uncommonly in a surgical ward, you can see patients who present who have hyponatremia within a couple of days post-operatively. So make sure that they're not getting IV fluids. And the third one, which you have to ensure, is what is probably I would call that a nemesis for medical students and for young doctors, is syndrome of inappropriate ADH. So what ADH does really is ADH makes sure that water doesn't leave the system. The body has got a classic mechanism, and it all happens in the distal tubule of the kidney, where the ADH attacks, and so therefore it tends to retain fluid inside the system. And this is all regulated by the osmoreceptors, which are present in the hypothalamus, and then it is also regulated by the renin-angiotensin system. So the renin-angiotensin system, along with the osmoreceptors, they all act together to make sure that the fluid balance stays in time. So syndrome of inappropriate ADH is that it's, as I say, it's a syndrome complex. There is more excess water which is retained. There'll be hyponatremia in these people, but because there is just water being retained and not sodium, SIADH patients will not have edema, and SIADH patients will not have a hypertension. You'll only get hypertension if the sodium level was high. These two things will be absent in a patient who's got high. If these two things are absent in a patient with hyponatremia, then this could very well be because of SIADH, syndrome of inappropriate ADH. And then how do you know that this could be syndrome of inappropriate? For instance, how do you come to the conclusion? The easiest way to do that is by measuring the urinary sodium. If the urinary sodium is less than 10, what you're dealing with is a classic case of a pre-renal cause. For instance, if somebody's lost fluid, that means somebody's got juvolemic hyponatremia, so somebody's lost a amount of fluid. In SIADH, you will see a value could be greater than 20 millimoles, and this value greater than 20 millimoles, it can be entirely normal as well. It depends on the degree of SIADH. So it can be less than 10, it can be between 10 to 20, it can be greater than 20, and this way you can actually tell whether or not they're they're consuming, they're actually retaining lots and lots of water. And SiADH will get a sodium value in the urine of greater than 20. The commonest causes of SiADH are basically twofold. If you suspect somebody of having SiADH, look at the two commonest areas. One of them is the brain trauma. Somebody's got meningitis, or they've had brain surgery. One of them is that, so the brain, and the other one is the lungs. Look at the lungs. They've got a pneumonia, they've got acute and chronic bronchitis, they've got a lung cancer. So these are the two areas. The third area for SiADH to look for is actually drugs. There are certain very commonly used drugs in SiADH. For instance, the fibrates which are used, that they cause SiADH. Then you've got glibenclamide, as I said earlier on. You've got glibenclamide, you've got the antidepressants. So these are the medications. There are several others. So when in doubt, always look at the list. Look at what the patient is taking, and so therefore this could be it could be SiADH as well. Once you were certain that, for instance, that what is the cause, then you can treat as well. As I said, euvolemic, you just need to give them saline. If there is excess water, for instance, you give them excess water, diurese them. You can give them a diuretic. So what a diuretic does, for instance, you give them a loop diuretic. What a diuretic will do is it will remove the excess water and therefore bring the sodium in water in balance. If you're in doubt whether or not they've actually got excess amount of water or whether they've got low salt, but you're not really sure, you can give a combination of a diuretic and saline, and till the sodium comes to a decent level, which is usually 125. If 125 is reached, then you can slowly and gradually, and you can titrate it upwards. But you can give a combination of furosemide along with normal saline in that situation. But what do you do with SiADH? Well, there are different things which are done. One of them is that you can use demeclocycline. Demeclocycline, what it does is it actually reverses that. So it causes diabetes, and it causes like a diabetes insipidus condition. And so therefore, the SiADH is reversed. And the other one is that you can restrict water to say about 800 ml to 1000 ml per day. But often water restriction doesn't really work much. What will work is the treating the underlying cause. So it is really de- debatable whether you should restrict water in patients who have got hyponatremia with suspected SAD. Often it does not work. What works is treat the underlying cause, and the underlying cause is going to work more. Now, I'm just going to briefly tell you after this one is there is a formula of water loss. So how do you know how much water is being lost? So there is a simplified formula for that, and that is weight in kilograms multiplied by 0.60. So weight in kilograms multiplied by 0.60. This gives you what is called as the actual total body water, ATBW. For instance, somebody weighs 70 kilograms, you multiplied that by 0.60. So this comes to be 42. So 42 kilograms or 42 liters, this is going to be the actual total body water. Then you take the serum sodium which is present. For instance, somebody's got a sodium of 128. Divide that by what is the desired sodium. Say for instance, this is 140. And you multiply that by the actual total body water. This gives you the normal total body water. That means the body water that is present. So this formula is going to give you that. And how do you calculate water deficit? And that is easy. And the easier one is NTBW minus ATBW. This is going to give you the liters of water that is deficient if somebody is got hyponatremia because of loss of water. So this is a formula, NTBW minus ATBW. This is going to give you the amount of water which you have to give, and so you can easily give that much amount of saline, and that should make it should correct that. So in a nutshell, hyponatremia can be tricky. Hyponatremia, if it's acute, it needs to be corrected because it can cause quite serious neurological problems. If it's chronic, you don't really have to panic. Just look at the underlying cause. But nevertheless, whether it's acute or whether it's chronic, it is associated with increased morbidity and increased mortality. So always compare the sodium level from the previous levels if you've got any available. Then clinically, which is the most important part of management, you make sure that the patient is not hypovolemic, the patient hasn't lost fluid from somewhere, the patient is not taking any medicines of any kind, or patient does not have anything extra or anything acute. Then you work out what kind of hyponatremia there is. Once you've worked out the kind of hyponatremia there is, then you can initiate treatment. But make sure that these are the two conditions that you have to keep in mind. One of them is hypertonic hyponatremia. That means, for example, if somebody drinks excessive amount of sugars, comes to the lab, has a blood sugar done, a blood test done, they can have a low sodium, mainly because of that. If you suspect that that is the case, remember for 100 milligrams of blood sugar above 100 milligram of baseline, you will expect a sodium to fall by about 1.6 millimoles per liter. For example, if somebody's got a blood sugar of 400, so you would expect that to be about 5 millimoles of sodium. So if the baseline was 135, you would expect the sodium to be measured sodium to be 130. You would think that this is hyponatremia of significance, but exactly because of the sugar. And the second one is pseudo hyponatremia caused by excessive triglycerides, that is plasma proteins. Why that happens? Because excessive amount of triglycerides, they will disperse the water. Normally, sodium is measured at approximately, assuming the machine assumes that there is 93% water present in the system. And so therefore, according to that, it's measured. But when you've got excessive amount of triglycerides, the 93, the value doesn't stay as such. So it is thought that the 93 is dispersed, so the sodium is going to come low. And so therefore, this is called a pseudo hyponatremia, which is just a lab finding. So the lab will often correct that. And then there comes the important concept of SIADH, syndrome of inappropriate ADH, caused by a number of things, can be idiopathic altogether, but it's caused by certain pathologies. One of them is drugs. Secondly, there is a problem with the brain. Thirdly, there's a problem with the lungs. If you've ruled out the brain and the lung pathology, look at the medicines. The person is taking some kind of medicine which is causing that. If it is if it's mild SIADH, you don't really have to, you just need to treat the underlying cause. If it's severe SIADH with a sodium level of less than 128, a sodium level of between 135 to 131, 128 is usually called as mild hyponatremia. From 128 to 121 is usually moderate hyponatremia. Less than 121 is severe hyponatremia. So it really depends. If it's severe hyponatremia caused by SIADH, treat the underlying cause. You can give them temeclocycline to reverse the effect. And otherwise, you can resist it. As I said, doesn't really work. But otherwise, just treat the underlying cause and you do not have to give them temeclocycline.